My name is Dr. Mark Time, I'm a paediatric consultant here at Poole Hospital and clinical director for paediatrics. And I look after lots of children in clinic with constipation and try to help them with their difficulties. Constipation's a difficult subject to talk about. It's generally where families are worried that their children are having difficulty passing their stools. Often they are opening their bowels less than 3 times a week, or they're having large, hard and difficult to pass stools, or even rabbit droppings or pellets. Some children do, however, have significant overflow where their stool is loose and smelly, and generally more obvious if children haven't had a large bowel motion for a while. When we see children with a history like that, we usually take quite a detailed history, talking about their sorry to talk about this in graphic detail, but we normally talk about their bowel motions when they were little and as a baby, so in the first 24, 48 hours of life, and then try and ask about their bowel motions as an infant, and then as a toddler when it came to toilet training, right up until the point where they present to secondary care with difficulties. We also ask about other things that might give you concern about other conditions. So, for example, a family history of inflammatory bowel disease or celiac disease, whether they have difficulty, particularly at night times, whether there's been an obvious trigger for the cycle of constipation, such as a recent viral illness or toilet training, or, for example, if they've gone to a new school and are struggling to get to the toilet on time. Generally, the studies have shown that of children suspected of having constipation, 95% of children just have functional constipation. We do investigations to make sure there isn't disease, but we generally only pick disease up in the 5% of children, and they tend to have other symptoms such as problems opening their bowels in the first 24 to 48 hours of life, failure to thrive, and losing a significant amount of weight, or other features such as significant blood mixed in with the stool, bloody diarrhea that wakes children up at night. And they would have abnormal investigations in terms of blood tests and stool tests. That's a really good question, and it's something that families are often very worried about. So generally, if you think about the sort of back passage, generally they may have a hard lump of stool and then sort of a loose stool flowing around the outside that's sneaking into the pants or undergarments without the child being aware of that. And that can happen several times a day, and it can be hugely worrying for parents, particularly if the child is given laxatives without parents understanding the mechanism for overflow, because otherwise they think their child has got loose stools and the laxatives are going to make things worse. Often the laxatives help to get rid of the large lump, and then the overflow reduces, and the stretched bowel that has been caused by the large lump of retained stool actually tones up over a period of weeks or months, and the child is more able to pass a more normal stool into the toilet. So what we'd find out about is a little bit about the motion at the time. So was the motion particularly large or painful or difficult to pass, as sometimes you can get a slight tear around the anal area, and then subsequent stools then cause, as they pass through the anus, can tear again and cause a little bit of bleeding with it. Generally, if it's fresh blood, either in the pan or on wiping, we are not as concerned. If it's slightly altered blood or blood that's mixed in with diarrhea-like stool, we will, of course, investigate and make sure that there isn't inflammation of the bowel causing that. Cancer in this age group is vanishingly rare in comparison to adults, where blood in the stool is much more of a red flag for cancer in adults. I think the bottom line answer is it's not just about the medicine. So when we're looking at a child and we're trying to help them get better, we need to think about other things that are really important as well. So their approach to the toilet, and whether they've got a positive experience sitting on the toilet to open their bowels. In terms of hydration, making sure that they're drinking enough in the day, because particularly children who are at school, or where there isn't quite as much supervision of their fluid intake, that can be a significant issue. The other thing is, are they having enough fruit and vegetables? Of course, the occasional fun treat and things like that is really important in a child's development, but also making sure they've got a reasonable intake of fruit and veg, which helps bulk out the stool and make it easier to pass. Some children can be really anxious about passing a stool, and they're in a sort of stool withholding cycle, and helping them to relax so that they don't hold on to stool is a really important step in their management. So if they're putting stool in the toilet, overall, the stool then becomes less hard. However, the longer they hang on to stool, because the body is still absorbing water, that stool becomes progressively hard and more difficult to pass. And medicine only really helps when the child is relaxed and able to sit on the toilet and finds a motion easier to pass psychologically. And in terms of the medicines we have two sorts of medicines. There are medicines that soften. So little babies may be given lactulose, which is a type of complex sugar. And older children may receive Movicol, which is a powder that is mixed with either water or squash. And then there's stimulants, which help the soften stool, if they're on softeners as well, helps the bowel to contract and push the stool through more easily. However, if all these medicines are based upon the principle that actually the child is happy to sit on the toilet and is comfortable there. And things like making the toilet environment more comfortable, making sure that they are happy to sit there, that there's a cushion if their bottom's slightly too small for the toilet opening, and perhaps reading to them or playing a fun game, blowing out bubbles, or and just laughing and joking whilst you're on the toilet, and making it a thing of praise when they sit on the toilet, even if they don't pass a motion. Making it a fun thing to sit on the toilet and part of the daily routine can hugely increase the chances of medicines working. The art of getting Movicol into children it depends on chatting to your child. I think in younger children, absolutely smuggling Movicol in can work for a while, but particularly children who are very cautious about what they taste, or for example, if they've got other associated problems such as autism, which make them much more reluctant to accept change, such as medications. Working with children so that they know that laxatives are going into their medicine actually helps build their trust in medications for the long term. And for example, so once you make that, say if you make the Movicol up in the morning, if you keep it in the fridge, so it's cold, if you mix some squash in with it, particularly if you mix Fanta in with it, it makes a kind of volcano of bubbles and can be quite fun for the child if you're looking to relieve the tedium of taking medications, but also have a reward system in place when they take their medications well. Also probably be a little bit conscious of the volume. Each sachet of Movicol probably needs 60 mils of water. So if they are on significant volumes of fluid for their Movicol, you might want to think about perhaps a stimulant as well as a softener, so that they don't quite need so much Movicol day to day, and they won't get quite so fed up with the taste quickly. These are all useful ways of helping to get Movicol down. The odd treat after having your Movicol as well is highly recommended. So for those families who are wanting web-based support, there is the ERIC website. It's a charity dedicated to helping children with bowel and bladder problems, and you can have a look on the ERIC website. And there are useful, not just reading material there, but there's also a watch that's you can get off the ERIC website that buzzes regularly, reminding the child to sit on the toilet as part of a toilet timing schedule. And you may find that half an hour after breakfast, lunch and dinner is the best time to encourage children to sit on the toilet, as their bowel is often quite active after a meal. But also podcasts such as this. I'm very grateful for you organising this. There's also the Wessex Healthier Together advice and information leaflets. NICE also do some suitable information. But also your GP, your health visitor, school nurse, you provide some useful advice in terms of primary care. And there's the paediatric continence service that have paediatric continence nurse attached that can also help provide not just advice, but some monitoring and also some continence products if, for example, liners or exercise nappies are needed in order to help the child function and not feel too constrained by their continence issues. For some children, we do need to see them in secondary care. And if there's red flag symptoms, we can refer them and consider further investigations from there. So the statistics are that, don't feel like this is a problem that can be sorted in a week or two. Do know that it takes time. I talked earlier a little bit about the bowel toning up, the bowel function improving, and that can take some time to get in place. Some children turn the corner really quickly with all of the right input in terms of the right fruit and veg, the right fluids, the right approach to toileting, and the right medications. But as you know, with medications, it can be difficult to know exactly what a child needs. So this can take a significant amount of time to adjust. And about 10% of children can still be on laxatives a year later. That doesn't mean that they've developed a lazy bowel. It just means that they're getting older, their confidence and their ability to communicate is progressing, and their understanding of their issue is improving. And it would be fair to say that, we hope to get the majority of children clean and sorted by the time they go to school, but that may not necessarily be the case. About 10% of children who go to school have continence issues, although it's not necessarily something that's often discussed in the playground. That does improve, so that by the time children are in their later primary school years, when actually other children may start to pay attention to these issues, a huge majority of children have become clean. Some children with additional issues may continue to have accidents into their teenage years, and that would take a different approach. But an individualized treatment plan absolutely is the way to help a child improve. There isn't a one-size-fits-all approach. It's about trying to work out what the individual triggers are for a child's constipation issues and trying to alleviate those issues as they arise. In terms of, so if there's continence products that help, the other thing is that children at the age of 4 don't always start school at full time. So there's normally a time to build up and get used to the school environment on a reduced timetable. And the other thing is that that visit before you start a school, it's really useful to work out where the toilets are and to show the child where the toilets are so that they can become more familiar and almost plan in their mind what would happen. Quite a few parents, when they're out and about with their children, are familiar with toilet mapping, where they work out, what would happen if a child has an accident in Sainsbury's or Tesco's, or, or if they're at a birthday party. And so school would be no different. I think the other things are chatting to school about a toilet pass and the ability to leave the classroom when they need to go and sit on the toilet if they are needing to go. The access to a clean and separate toilet can also be really useful, because sometimes children are worried about going into a cubicle and making a noise or a nasty smell and being picked up for that. And every school has access to either a toilet attached to the medical room or disabled toilet that they can have a pass to, so that they can go there and change clothes, or use continence products, or and be able to continue their school life normally without fear of the toilets in school. I'm sure we all remember our own school toilets and can interpret their school their toileting needs accordingly. And the other thing is that the continence nurse can help support that integration into school and that confidence. Fundamentally, if you've got a supportive school teacher, that makes a huge difference. And some schools may need either the continence nurse or hospital support with an intimate care plan to help the changing if needed. If there's no signs of improvement by improving the trigger factors, if you see what I mean, if you're needing continence products, if you're needing or also you're reaching the end of the line as to what your GP or school nurse can offer, that would be the time to ask for a referral. Many GPs are very confident at managing children with constipation, and that understanding that it is a medium-term issue that needs help and support. The other thing would be to make sure that if laxatives are being stopped too soon, or or the child is just having laxatives as and when needed, when actually they're having accidents regularly, the continence nurse can support assessment of the need for laxatives and encourage regular laxatives for a prolonged period, which would be the best way of helping children with chronic constipation improve.